Thank you so much, Mary. And it is my great pleasure to introduce Jean Chia, who joined the Stanford faculty as a clinical assistant professor in the Division of General Pediatrics just 2 years ago. She completed medical school at Northwestern University's Feinberg School of Medicine and her pediatric residency at New York University before entering a 3-year T32 National Research Service Award or NERSA fellowship in general pediatric research at Cincinnati Children's Hospital. During that fellowship, she also completed a master's degree in clinical and translational research. And while at Cincinnati Children's, Dr. Chia helped co-create a new training program in the care of children with medical complexity. And she was a finalist for the Compassionate Caregiver Award in recognition of her service to children with medical complexity. She has presented her fellowship research on goal-centered care and shared care plans for medically complex children in platform presentations at the Pediatric Academic Societies meetings. And since joining us at Stanford, she has also served as one of the primary medical providers at the Complex Primary Care Clinic, alongside myself, Dr. Meera Sukumaran, and David Bergman, who founded the clinic. In addition to serving as the director of the residency rotation in complex care, Dr. Chia serves on the intern selection committee and the telehealth work group within the department. In these 2 short years, our colleagues in our Division of General Pediatrics and I have grown to know Dr. Chia as a consummate professional, as a wonderful teacher, as a trusted advisor, and as a devoted medical provider to so many vulnerable children and their families. Dr. Chia, we look forward to learning from you.
Thanks very much to Mary and Lee, and thanks everyone for joining us this morning. I'm humbled to give this talk in honor of Disability Awareness Month. Our talk today is titled Care Coordination for Children with Medical Complexity. I have no conflicts of interest to disclose. Today in this talk, we're going to define children with medical complexity, often referred to as CMC, which I'll also refer to that abbreviation in this talk, and their impact on the US healthcare system, understand the need for care coordination in current models of care, and understand the role of eliciting patient and family stated goals and the incorporation of these goals into care plans. First, with the definitions, children with medical complexity, again, CMC, also known often as medically complex or complex chronic, have significant chronic health problems or disease that affect multiple organ systems. Commonly, 3 or more major organ systems is recognized as the norm, and often result in significant functional limitations or disabilities, high healthcare need or utilization, and often the use of medical technology. And we'll go through an example. But some numbers first. So children with medical complexity, CMC, are a very small number of the US pediatric population, comprising just 1% of children in the US. But they do use up to 1/3 of all child healthcare costs in the US. And looking at this pyramid, so most children at the bottom of the pyramid, what we would consider healthy children, are non-complex, non-chronic. They are healthy, they don't have chronic complex disease. 10 to 15% of children in the US are what we would call children and youth with special healthcare needs, often abbreviated CYSHCN. These are children that have non-complex chronic disease. And then within that 10 to 15%, the very top 1% would be children with medical complexity as we defined. I do just want to acknowledge here that although not referring to it today for the purpose of this talk where we're talking about children with medical complexity, but children that have significant behavioral or mental health complexities can be equally as debilitating and equally as high health care utilizers. But today we will be just focusing mostly on CMC. As we go through this presentation, please consider as an example, if you are caring for a child with gross motor functional classification system level 5, spastic quadriplegic cerebral palsy. We said that children with CMC often have technology dependence, and this child with cerebral palsy has tracheostomy dependence. He is mechanically ventilated. He has a G tube, he is gastrostomy tube dependent. With refractory epilepsy, has a vagal nerve stimulator and requires airway clearance management. Also, with regards to this child's disabilities or functional limitations, He has cortical visual impairment. At baseline, this child is nonverbal and non-ambulatory, has a history of long bone fractures and osteoporosis, and a chronic dislocated hip with neuromuscular scoliosis. And this child is 100% dependent on his caregivers for all activities of daily life. But also, he has a neurogenic bladder that requires clean intermittent catheterization and a history of a repaired atrial septal defect. The family for this medically complex child has 3 separate vendors that they manage for his supplies, for his respiratory, enteral, and continence cath supplies. And in the past year, this child has had 3 ICU admissions. They see 10 subspecialties as listed here. And within the community, this child needs special education with an individualized education plan and therapies at school. He has California Children's Services medical therapy program where he goes to the medical therapy unit for therapies. They are established with the regional center, and the family is also plugged into respite care when needed. And in that kind of clinical scenario we just went through, this is another just really well drawn out illustration created by a mother of a child with medical complexity as a care map to represent all the aspects of her child's life. And if I can orient you, so the child G in the center here, surrounded by their family. And then in the blue at the bottom left corner, you can see all the subspecialties listed, dental, as well as the specialty hospitals, medications and equipment that's required, the specialty pharmacy, the local pharmacy, the toileting supplies, braces, et cetera. In the purple, the developmental assessments with neuropsychoeducational evaluations, speech and therapies. Up in the top left with school, everything that's needed with regards to transportation, to special ed, ABA therapies. In the light blue at the top right, advocacy and leadership, the family is involved with other groups and family voices and important other parent groups. Recreation and community on the right. In the red, all the legal and financial considerations that come into play. In the green, of course, their support, their family, their friends, their community. And I do just want to say, in this very detailed care map, we are here only in the blue, only a fraction of their day-to-day. I'd like to just share this quote, a part of a parent, Miss Debbie Harris's reflections titled "The Category of Us," published in the Complex Care Journal, which is an open access journal. And I really encourage everybody to read it if they have the chance. It's powerfully written, describing, not only her experience as a complex care mom, but also as an African-American family navigating the healthcare system today. And she says, "Uneventful days are welcome retreats from the difficult ones." If I could read this for you. "Bed baths 3 times a day, full immersion baths with jets to help relax tone using the ceiling lift, 3 times a week with the panic button ready to call Lifelink, oral cares, peri-cares, trach cares, scheduled meds 3 times daily, not counting as needed, explosive stools, change all of the bedding, do it again, feeding tube cares, 24-hour continuous feedings, oximetry, titrate O2, reposition every 2 hours, take your hand off your vent tubing, you'll pull your trach out. There's a storm coming, John, go downstairs and unplug your brother." And although many of us may care for children like this, very few of us can truly say that we've walked these shoes in a day in the life of these families. The impact on families, as far as the psychosocial burden, is also incredibly large. Families of CMC experience various challenges associated with the burden of caring for their child that has complex chronic conditions, including but not limited to financial and employment difficulties, marital, sibling, and home life, mental and emotional stressors, and many more. And just as an example, so this is from the National Alliance for Caregiving a couple years ago. So just the caregiver impact on work. And shown here in this study, they did include caregivers for children as well as adults. And in the red box in the blue are the caregivers for children. And you can see with regards to work, employment, in all areas, whether it's taking time off, going to part-time, all the way to entirely giving up work or retiring early, parents that care for their children as caregivers in all domains here compared to caregivers of adults had larger impacts on work. And, just to highlight in the second box, over half of all parents that care for medically complex children go part-time, and oftentimes it is usually the mother, more so than the father. Also, with regards to family impact, shown here from Dr. Dennis Quo's 2011 kind of study, which pulled from the National Survey of Children with Special Healthcare Needs from 2005 to 2006. Just highlighted here in the red box for you is that in the more complex children that responded to this survey, reporting on their family care burden, they spent 2 hours per week on average for care coordination for their child, and 11 to 20 hours per week providing direct home care. And I actually do think that this is a little bit of an underestimation. And part of that is, they did in their definition define the more medically complex in this group as seeing 2 or more specialists in the last 12 months. And we know that frequently our CMC kids really see much more. So I think if it was a little more stringent, I really think families spend much more than 2 hours a week care coordinating for their child. With regards to thinking about advocacy pieces, we know that 40% of children are covered by Medicaid or CHIP eligible in the US, and 2/3 of children with medical complexity are covered by Medicaid. These numbers I think are even larger now in California. I think now more than 1 in 2 children have Medicaid. And despite knowing that all of these children are frequently plugged into tertiary hospitals and academic centers, many care gaps still exist for these families. We already spoke about the financial burden, over half of them reporting financial problems. But almost half of all families also reported at least one unmet medical service need, and 1/3 reporting difficulty in accessing non-medical services. So that may be things like early start, community resources, things that can be provided for therapy or regional center, for example. So understanding why care coordination is especially important, we just went through, but just now a definition. So it's a little bit long, but I really do like this one. So care coordination is a patient and family-centered, assessment-driven, team-based activity designed to meet the needs of children and youth while enhancing the caregiving capabilities of families. Care coordination addresses interrelated medical, social, developmental, behavioral, educational, and financial needs to achieve optimal health and wellness outcomes. So the framework really should be, number 1, patient and family-centered. Number 2, proactive, meaning that you're planning ahead instead of reactive when a problem arises, and comprehensive. Number 3, promoting self-care skills and independence, so self-management. And number 4, emphasizing cross-organizational relationships. This graphic is taken from NASHP, National Academy for State Health Policy. So kind of just illustrating what our national standards are for care coordination for children with special healthcare needs, which would include children with medical complexity. So again, just, with the child and the family here in the circle at the top left, surrounded by their care teams. And then, important aspects include, shown here at the bottom, a care coordination workforce. So really providing team-based care, not just a provider or a doctor or a nurse practitioner, but other team members that can help with the care coordination aspects of care transitions, team-based communications, child and family empowerment and skill development. Again, self-management piece is really important. And ultimately, all leading to shared plans of care, and a part of that, reassessment with screening, identification, kind of in this loop together. Currently, there's three main models of care delivery for children with medical complexity. First being primary care centered models, and I'll kind of go into more detail about this. Our clinic, the complex primary care clinic, would fall into this category. So we are a medical home. We act as the PCP for the most part, and do provide primary or preventative care in addition to other care coordination services. Number two, consultative or co-management centered models. So these may be complex care programs at a hospital or an academic center, or even subspecialty providers that partner with PCPs for families, but the primary care aspect is separate for these children. And then number three, episode-based models. So these are, for example, if there's a complex care program that just sees kids when there's a deterioration of status, or like a transitional facility where kids may be staying when they're waiting for in between hospitalization and training to go home, may be also considered an episode-based model. So that's the smallest population. I do just want to also give out the disclaimer that I am a general pediatrician, and so I definitely do have the bias towards primary care centered models and medical homes being what I view to be really a best practice for CMC. With CMC and their primary care, we do know that 40 to 48% of children with medical complexity go without an annual primary care visit. These are from studies at Boston Children's and also confirmed at Cincinnati, respectively, 40 to 40%. As a result, many preventative care gaps and delayed vaccines do exist. For example, at Cincinnati, just 28% of CMC under the age of 7 received all the recommended vaccines for which they were eligible before they really implemented some system-wide changes. And barriers do exist. 43% of pediatricians in the US endorse subspecialty care potentially as being the best source of a medical home for children with especially complex or rare conditions. And usually when this is the case, they cite time and cost as barriers in their practice. Though we do know, of course, there are many excellent pediatricians that take very good care of CMC in their clinics. But as a result of outpatient primary care generally being oriented to providing service for our healthy, neurotypical children, out in the past decade, outpatient primary care programs specifically for complex care children have really emerged to meet these unique needs. Our clinic, which I'll talk about later, is about 9 years now. Just moving into some of our projects that I want to highlight that are especially important for talking about care coordination for CMC. The Centers for Medicare and Medicaid Innovation Award, CMMI, was awarded to the Children's Hospital Association. This is also known as the CARE Award, led by our very own Dr. David Bergman, who is the founder of our complex primary care clinic about 9 years ago here. And the CARE Award, which stands for Coordinating All Resources Effectively, really sought to address care model innovation and payment reform for Medicaid children with medical complexity. And it was the first study to demonstrate reduction in spending for CMC in complex care centers and general primary care practice clinics with comprehensive care management. So really important work. And with this CARE Award, the Learning Collaborative across these 10 hospitals had 4 key change concepts in their intervention that that each center included, with one being providing a dynamic care team list for the family, a list including all of their providers and team members, shared care plans. Number 3, access plans or contingency plans. So also sometimes for contingency plans, like, who to call for certain conditions, when to go to the emergency room, things like that. And also a patient registry for reassessment and stratification. In the Care Award project, they found that comprehensive care coordination services was associated with much, in several different areas, decreased spending, 7.6 decreased inpatient spending, 11.6% decreased emergency department costs, 4.6% decreased per member per year costs, and very important as well, of course, improved family experience. So we know that care coordination is effective and important, but how do we incorporate family-centered care plans into the shared care plans for all families? Well, families are key members of the care team and experts in their child. Shared family-centered goals are recognized as key elements of care plans. And system standards for medical home care coordination includes respect of the family's strengths and incorporation of the family-driven or family-stated goals. However, gaps still sometimes do exist, often do exist, between the child and family's values or priorities and those of the pediatrician or provider creating the care plans. And this was some of my projects that started when I was a fellow at Cincinnati, but I was really interested in understanding and describing how often various types of patient and family stated goals were addressed with an action plan. So over a 3-year period for children 0 to 21 years, we looked at almost 1,500 children that were enrolled in our care management program. So they were assigned a care coordinator at one of our 4 primary care practices, 3 of which were general pediatric clinics, and 1 was a complex care center that also was a medical home. And medical and social complexity was based on a validated pediatric medical complexity algorithm, and the social complexity was based on social work assessments. And each of these families enrolled in our care management program had at minimum every 6 months would have their goals elicited by the nurse or social work care manager and documented in their plan of care and shared with all the visible and shared with all the teams as well as the family. And we first used an inductive qualitative research approach to categorize these goals. Our multidisciplinary team included 3 pediatricians, 2 parents of children with medical complexity, and a social worker. And this was intentional to just avoid a provider mental model with the naming and the sorting and refining of our goal categories. And we did this until we reached thematic saturation, ultimately coming up with 15 different goal categories that I'll go through. And then the second piece later on, we randomly sampled 780 children of these to assess whether or not the goal included an action strategy that addressed the stated goal. So the first piece was identifying and developing the different goal categories. And then the second piece was, well, now that we're eliciting these goals, how good of a job are we doing actually coming up with a plan that addresses what the family says is their main priority? Within these 15 goals, 3 major themes arose. So shown in red, less than half, actually surprising to us at the time, 47% of the goals fell into a clinical related theme. Just over a third, 36%, were a behavior and development related goal. And 16%, which I really want to take a pause and emphasize, 16% when asked, families stated, like, what is the most important goal or priority for you right now for your child? 16% actually had a social related goal. And just shown here are the 7 different clinical goal categories. Again, the naming of these goal categories was with the assistance of the parents that worked alongside us in this project. So we categorized them as medical, nutrition, growth, exercise, future wellness, therapies, families, child self-management of medical problems, decreasing medical support technology dependence, and access to healthcare services. 4 goals within behavior and development. So development, behavior, school, and mental health psychiatry. And 4 goal types within the social category, named as housing, financial support, home life, and custody. And just as an example, so shown here for the 4 goal categories under social, housing, for example, at a frequency of 6.2% for our goals. As an example, one parent said, "Mom," and this is the care manager paraphrasing, but "Mom's goal is to move to a new and safer neighborhood." And so what we looked at was, and with regards to this goal, how often were the PCPs addressing this goal with an action in the care plan, and how often were care managers addressing the goal? So with this housing example, 20% of providers addressed it versus 72% of care managers addressed it. And then in the furthest right-hand column, when combined together, so really emphasizing when we looked at did the provider or the care manager addressed it, almost 88% of the housing goals were addressed. Again, as an example, financial support. The example goal being mom wants to go off food stamps. Providers addressed this goal stated by the parent during that visit less than a third of the time in their care plan for the child. Care managers addressed it just over 2/3, 67.9% of the time. And the asterisk is just that these are statistically significant differences. And when combined together, either provider or care manager that addressed the plan, almost 80%. Just to show you an example of a clinical related goal. So under the category of decreasing medical support or technology dependence, the example being here is a parent said, "My biggest goal is for her to be decannulated." So here, providers that saw this goal addressed it with something in their care plan, a next step or an action step, 68.8% of the time. Care managers addressed this family goal, 78.3%. And this was not significantly different. And then together, over 80% addressed. So really, again, going back to our 3 main categories, when we looked at the clinical goals, the behavior and development goals, the social goals, in the first row, clinical, we really, relatively speaking, did quite well with providers and care managers. Almost 75% of the time would consistently address the patient's stated goal with an action plan. And there was no difference there. However, behavior and development related goals and social goals were significantly much more frequently addressed with an action by the care manager than the provider. Again, highlighting here, the social goals were addressed by the provider less than a third of the time, and then 69% by the care managers. But what's perhaps reassuring is, if we look together as a team in all categories, almost 80% or over 80% of the time, a provider or a care manager is coming up with an action strategy that does address the patient and family stated goal. So really highlighting how strong we work together as a team to make sure we don't miss any care gaps for patients. So in our work, our findings included that CMC and their families have diverse needs and priorities that are variably addressed with an action plan. It may appear that care managers comprehensively address different goal types, which is very important learning for us as we think about how to lead care planning. And as I said, team-based care plans really were showing us that they were doing a much better job at supporting families' goals. So, as again, with the example of the social goals being addressed by the provider less than a third of the time, without the care manager's support, a lot of those family priorities and social related goals would have been unmet. But what we don't know, additional research is needed to understand whether robust care plans or goal-directed care plans impact child and family healthcare outcomes. On a related note, and I have to thank Lee Sanders for sharing these slides with us, for the Goalkeeper Project, which our child neurology colleagues here also, a big thank you to them for their participation and support in this project that is completed and has some preliminary results that I'll share today. But in this project, in collaboration with Dr. Jody Lin at Utah and folks at Harvard, mental models of health goals differ between providers and patient and families, as we spoke about. And oftentimes the care is provider problem centered, but not family or goal centered. As a part of this work, they created a 3-level family-centered goal taxonomy to help them analyze the goals that were being said. And this research informed Goalkeeper, which was a tool used in ambulatory care of children with medical complexity that had 3 separate attributes: provider training, goal elicitation, and goal tracking. And then finally, randomized controlled trial of Goalkeeper showing efficacy in goal setting and shared decision-making. And some preliminary results that are in press. So, in all aspects, the control group is in each of these 4 charts is shown in blue. And although a small study, there is a strong signal towards maintenance of goal setting, problem solving, care coordination quality when using the Goalkeeper tool. So although it looks like, over time, the control group, which is the blue, went down in each one's, the groups that had the intervention stayed the same. So is reassuring. And I do just want to wrap up and also introduce ourselves in the complex primary care clinic. So what are we? We provide a medical home for children with medical complexity. And we serve children that are cared for by 3 or more pediatric or surgical subspecialists, children that are technology dependent, children that have frequent or prolonged complicated hospitalizations. Our team here is just shown here. And I really need to highlight and shout out our core team, which if you recall the 3 models that of care delivery that I had shown earlier: primary care, consultative, and episode-based care. The core team is really a virtual team that kind of transcends these 3 recognized models. So we are so fortunate to have our core colleagues helping to provide care coordination for our kids here. The core program stands for coordinating and optimizing resources effectively. They have dedicated care managers, case managers, parent mentors under the leadership of Dr. Karen Wayman. Also a CCL, care coordinators and schedulers, and a social worker, and led by Dr. Karen Wayman and Dr. John Mark. And as I said, it is a virtual clinic that is a flex model designed to meet the care coordination needs of patients. So they're a little bit different in that they, unlike us, they're not a medical home, but they're also not consultative. They see patients inpatient to do warm handoffs, and they can meet them at ambulatory appointments. They have a lot of touch points with families to meet their diverse set of needs. Shown here, I just want to call out to the volume of encounters that our core colleagues encounter. So 20 to 25 daily face-to-face encounters, 400 to 500 per month, and 35 daily virtual telehealth or phone encounters, 700 per month. For anybody looking to refer to either of our programs, if you're in need of a medical home for a child with medical complexity and feel that they would be well suited for us and that we would be a good fit for the family, in EPIC, if it's internal, you can place an ambulatory referral to complex care. And for the core program for families that have intensive care coordination needs, You can place an ambulatory referral to the core program. And in summary today, as we wrap up, I just want to again highlight that children with medical complexity, CMC, are a small, again, 1% in the US pediatric population, small population, but very high needs population. Family-centered care coordination for children with medical complexity is both crucial and effective. With Dr. Bergman's work and the Children's Hospital Association and the Care Award has been shown also to reduce spending. Remember the importance of incorporating family goals and needs and highlighting family strengths when caring for all of our patients. And in honor, just since of Disability Awareness Month, I just really want to also mention, with regards to health equity, and all the diversity, equity, inclusion work and focus here that we have at Packard and Stanford and nationally, we know that care gaps exist for families of children with medical complexity. They may also deal with racial language barriers, but inherently we know that the psychosocial burden is tremendous for these families. I think it's important that we also emphasize and recognize disability rights and making sure that we do strive for health justice for this small group of children that cannot advocate for themselves. And if I can borrow the words of one of our parent mentors, Teresa, who has said to me that our complex care children, they may not speak well or they may not speak at all, but they definitely do have their own language. And sometimes they really need us to be that voice. I do also want to just end again on Ms. Harris's reflection piece, the category of us, a quote from her reflection describing parents of children with medical complexity. She says, "We are part of a demographic that cares for children who are medically with a host of disabilities, coaxing them towards adulthood against all odds." I have many people to thank, including our complex care team, our core team colleagues, the Division of General Pediatrics in the department, as well as my previous research team and mentors. And I want to thank everyone for their time and their attention. Please email me or any of us if you have any questions, ideas, comments, thoughts of how we can work together and improve care for our families. Thanks very much.
Jean, that was phenomenal. We have a number of questions coming in the Q&A, and I encourage people to add their questions for you. I'll read them out loud to you, also for the people that are listening in. The first one comes from Holly Henry. She says, "Great presentation, Dr. Chia. What do you think are the most pressing healthcare system issues that need to be addressed to improve access to and quality of care coordination for children with medical complexity?"
Yeah, so thank you very much for that question, and so important. So access, we know to be a huge issue in itself. Although, I kind of highlighted our complex care program and, for example, the Care Award project that I mentioned, which was at 10 children's hospitals, each with their own complex care programs. Most children, the majority of CMC children with medical complexity, do not belong to a complex care center or complex care medical home. So, we know that most children, even those that are medically complex, have medical homes with their PCPs nationally. So, improving care coordination and access for these children, really, I think the care management piece is so important, making sure we have really a dynamic team of care coordinators, of nurse and social work care managers, pharmacists, nutritionists. We're so lucky to have parent mentors, but, these innovative things like the core program that we have here I think are a good starting point and a really novel starting point. But these are ways that we can kind of disseminate into primary care practices and clinics where PCPs may not have the time or other resources. And of course, even within our own institutions too, making sure that we build support for these team members, I think is really key. And again, with regards to access and improving that aspect of care, I think really education for our trainees is a huge piece too. I can't help but plug our elective if anyone wants to come rotate with us in our complex care clinic. But, there really, I think, needs to be an emphasis in our trainees for our pediatric residents about just learning the nuances of ambulatory care for these families and how to lead the care coordination and being comfortable managing care plans and making sure that they're addressing family priorities. I know that was a lot in one response, but I hope I answered your question somewhat.
That was great, Jean. It was a big question, but good answer. I would add just briefly, parenthetically, also fellowship training in complex care that you were part of and that we're developing within our own Gen Peds fellowship. There are a number of questions here, Jean, about the complex care services. So I'm just going to go through them. The first one from Dr. Aby in our division: as a medical home for CMC, is our complex care clinic also open to siblings who do not have medical complexity? Can the child bring the child and the sibling together for regular checkups, or do they have to choose a different one for the siblings?
We do have some healthy siblings that have been grandfathered into our clinic. Because our team is so small right now, we only have the 4 providers that I kind of put up earlier. We don't really have the capacity to universally right now accept all well siblings as well. But, I think that for example, at Colorado Children's, they have a special care clinic that is a hybrid model where, it's their complex care program is housed within their larger primary care clinics, and is one that is a great model for care for families. And I think it would be so wonderful if we could take on all the healthy siblings also, but because of our clinic limitations right now with people and staff and space, we're really currently best suited to take on families where we're providing care just for the child that has the medical complexity. But conversation is to be continued.
Thanks, Jean. There are a couple questions about patients who live more remotely. From John Mark: could you mention how you care for patients and families who do not live in the immediate area? And from Dana: my complex rheumatology patients have really loved the program. How has your team transitioned to telemedicine during the pandemic?
Yeah, so I started November of 2019, right before the pandemic. And even when I started back then, our clinic and my colleagues, Lee, David, and Mira, all of us had been doing telehealth pre-pandemic, although those visits were oftentimes much more related to, school needs or conservatorship kind of type of visits. And we've really ramped it up to include acute visits or sick visits or other well child visits as well. I think telehealth, will forever be with us and will be so important to improve access for children that do live in areas where access is a challenge. For example, here we have, it's really heartbreaking that we have families driving 4 or 5 hours one way up from the valley to see us because they have no other option. And so we oftentimes will as much as we can, provide telehealth for these families, since we will partner with local PCPs in those situations because they need someone much closer. They can't come 5 hours when they, have an acute respiratory illness. So, I think telehealth will be here to stay, and I look forward to what it brings us in the future. But I think it will be so important to make sure we're reaching families. And even our local families, I just want to add, not only those that have distance, but I've found that our local families really appreciate the telehealth visits too, because some of our kids, it's so much work to get them out of the house. They've got equipment and they come with pulse ox and continuous feeds, or they have their TPN bag hanging, and it's just even lifting the child to and from. It's such an ordeal. It can take families an hour or more just to get them ready to get in the car for a trip. So families are so appreciative of telehealth.
That's great, Jean. There are also a couple questions about transition care and transfer of care. So from Dana, how does your group handle transitions to adult providers? And Linda Starnes asks also about the transfer of patients to adult services.
Yeah, so thank you for asking that very important question. And it's something that I think all of us in our group are quite devoted to supporting families with. We never discharge children until they have established with adult care. And in general, we'll tell families we'll see them until age 23 typically, but I think we definitely have a couple that are getting into their late 20s, but we really kind of start helping the family navigate starting their adolescent years, thinking about conservatorship, kind of just thinking about what specialties they will have to move over to the adult side. We tend to move the subspecialty pieces first to make sure that the process is smooth. And then the last step will be moving us, the PCP, over to an adult primary care. One challenge has been, as I mentioned, the vast majority of our children are Medi-Cal or CCS, California Children's Service, which they'll age out of at 21 and revert back to Medi-Cal. So finding them a primary care adult medical home has been a challenge locally too. For example, their subspecialty care can be seen with our adult colleagues at Stanford, but not their primary care. So it does create challenges for making sure that their new adult PCP is able to provide the same quality of communication and partnership with their specialists. But, we definitely take on some, 17, 18-year-old patients that we help transition when that need does arise. But we work with the families to find the best fit for them.
Great, Jean. Now, at the other end of childhood, there are a couple questions, some related, and some not, from our colleagues in neonatology. So Phil Sunshine asks, how do you coordinate care for a patient who has issues in multiple organ systems? He says renal, GI, pulmonary, and cardiac. And Joachim Profit asks about how healthcare providers, I presume that means, can learn to effectively and efficiently partner with community-based social support organizations. Neonatology would like to learn how to do this better from Gen Peds. So those are two big areas from our neonatology colleagues, but I figured I'd group them together.
Yeah, thank you. So for the first question about how do we coordinate when there's multiple specialties? Well, for example, if a very complex child is graduating or discharging from the NICU, we do try to see them within a day or two of discharge. Oftentimes for the most complex children, again, we are so lucky, and I cannot say this enough, to have the core program here with us at Packard, because they really are the glue that holds it all together, and they can help the family learn the education pieces of navigating the health system. They can help with transportation when that arises, for example, if it's a mechanically ventilated child. And they can do a lot of the developing the self-management skills with the parents that will long-term support them. For families that are not eligible for the core program here, then we help as much as we can, depending on what the parents' needs are. So, for example, in the beginning, right out of the NICU, a lot of times it's as much as just helping the family get familiar with the different vendors they may have, the appointments that they need, making sure they have MyChart access, that they can do telehealth visits, that they have that they know who all of their providers are. Again, remembering having a dynamic care team list is really important. So they know who their nephrologist is, who their GI doctor is, who their pulmonologist is, their medical home is with us in complex care. What are the numbers to reach, each of these? What are the on-call numbers to reach each of these people? And helping with those aspects in the beginning, coming from a NICU discharge is a lot of times what we do. And then after plugging the child into community resources, which kind of getting into the second question too. So, if they haven't already from the NICU, which oftentimes does a very good job, but making sure that the child is established with early intervention through the regional center, if that's appropriate, making sure that they may have CCS insurance or that they get therapies at the CCS medical therapy units or programs, that the resources that we have in California are available to them locally. And then, was there anything, Lee, that I didn't address from the second question? It was more about
how our colleagues can learn more about how to coordinate with community-based organizations. Yeah, no, I think you did a good job of describing that.
Yeah, I mean, how to depending on what the community-based partner that you're trying to get a hold of or learn more about is, I would say, when I started, I think Cynthia, the core social worker, taught me probably 99% of what I know about community resources and also our parent mentors. So, I'm happy to, after this or offline, if we can, be of any resource to kind of help with just walking through what some of the probably most likely resources that you'll need are, or connecting you to some of the parent mentors or our colleagues in the core program that really are very familiar with these programs. But a lot of times, I think the NICU does a good job, but knowing what the resources are that are available is just the first step.
Yeah. So Jean, we only have a couple minutes left. There's one really focused question, one big question. So I'm just giving you, so the really focused question is around care management ratios. Did you mention the right ratio between care manager and families? Do you cap the number of patients who can receive this care coordination?
So within our clinic here, in the complex primary care clinic at Packard, we do not have our own designated care managers. We do have a CCL, a care coordinator liaison. She does not have a Daisy. She does not have a patient cap. She is our jack of all trades. I can't speak to the core program's capacity or cap level, but I do know, for example, at other institutions, there may be a goal of for like a set at a caseload of 60 to 90 patients per nurse or social work care manager in my previous experience. But I think so much of the time our team members are a limited resource that we have, so they take on way more than that. Like our core program here has one nurse care manager, one nurse case manager, one social worker, and they take on, as I showed you the numbers, over the 750 active and graduated core program patients by themselves. So it's a feat, an incredible feat.
Right. I'll just add that, you mentioned we have one CCL on more than 500 families in complex care, and the national ratios are between that 50 and 500 for care manager. But and it's tough. It's a resource constraint. So thank you, Jean. Okay, the last question is a big moral question, and it comes from an anonymous attendee, but I imagine it's on the minds of many people. Is the benefit worth the cost to patient, families, providers, and society generally? This attendee says that most doctors decline their own extraordinary end-of-life measures that they impose upon their patients. I believe this is from an adult study. And since patients cannot advocate for themselves, what's the moral imperative here in your view?
Is it worth the cost? In my mind, yes, absolutely. And, any goals of care, I think, is the family's decision and the family's choice. And we're there to help them, support them, understand their disease process, and provide resources and knowledge and education and support. But with regards to, is the benefit worth the cost? I don't personally think that we can put a cost or a number on the value of a family's child or that child's quality of life. I think that's very family dependent, and it depends on each family's values and situation.
Jean, you've clearly demonstrated us that value in the way that you do your work and the way what you've taught us today. So I want to thank you for your time and thank everybody for attending. I also want to note that Holly Henry has put in some resources from the Lucille Packard Foundation for Child Health, which has really been a national leader in providing resources in this area. And just thank you for enlightening us today, Dr. Chia. Thank you all.
Thank you very much.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.